Now, how will the history look like? Because the enabling objective said with each of the conditions, you must know the history, the physical exam, the appropriate investigations, and the appropriate initial management. So how will a child with colic present historically? Historically. So please, I need someone to read this question for us.
You are evaluating the 2-month-old female infant with ongoing paroxysms of high-pitched cry for the past 3 days. List 4 possible causes of the child's concern.
Good. Please.
One from different system each.
Beautiful. Please don't be tunnel vision because we are talking about colic. No. Don't only think about colic. And even the question is saying one from each different system each. So please, if you have a child who is brought to the emergency room or to your clinic with inconsolable cry, what are some of your differentials? Please type your answers in the comment section, like the way you type it in the exam. Please type your answers. Child with high-pitched cry. If you're supposed to list something from gastrointestinal system, otorhinolaryngology, dermatology, cardiovascular, what are going to be your differentials? 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 Feel free, feel free to write your answers and then, yeah. So I've seen some intussusception. Meningitis, beautiful. Dr. Sabin, awesome. Dr. Sahar, awesome. Low abdomen. You see, I like the way Dr. Kano now answers his questions. Dr. Kano, what has changed? What has changed? I like the way you answer your questions. I really do. What has changed? Tell me, what has changed? Now you are spot on. What has changed, Dr. Kano? I like the way you're answering your questions. Yeah. What has changed? What has changed in the way you are approaching your cases now?
It's the key you gave us, sir.
What key is that?
Approaching things system by system.
Simple. I really like the way you put your answers. So, general causes of crying in a child. It could be drug ingestion or overdose, right? So, like pseudoephedrine. So, in your history, you want to assess, has there been a history of medication administration? No, it could just be that the child is hungry. Nobody is talking about that, right? So signs of hypovolemia or undernutrition, like maybe a child is sunken fontanelle, dry mucous membranes, decreased subcutaneous fat, right? Then it could even be neonatal abstinence syndrome. And how would that present on history? So you realize that what I'm trying to do whenever we are doing these classes is not just to focus on the topic alone, but everything which surrounds the topic, I want us to deal with it. So neonatal abstinence syndrome, what is it? So if you want to, how will you make sure you diagnose a child with neonatal abstinence syndrome in your MCQs or in your CDMs? Maternal history of prenatal substance use or positive urine screen. So if you have a child who was born to a mother who used to be on methamphetamine or cocaine or opioids. So if you're giving that in your question stem, then you're thinking about neonatal abstinence syndrome. Or maybe the child is withdrawing, right? Because the child is used to that. What about skin-related conditions that can lead to fussing and crying in the child? It could be that there's a hair tourniquet of the digits or the penis. Because, maybe the mother may have long hair and it might have tied around the digits. Then it could be, diaper rash. It could be trauma. And that one, you can find it on physical exam. Hello, doctors, please. I don't want to rush it. Are we tracking? Yeah. Someone wrote eczema because eczema, Dr. Wally, because eczema can be itchy. It can be itchy. And the child can cry a lot. So we've looked at general causes of fussing child. We are looking at dermatological causes. Now let's go to ophthalmological causes, eye causes. It could be corneal abrasion. Some of these kids, they have long fingernails and they might have scratched their eye. It could be foreign body. Okay. And with foreign body, you can do a positive fluorescein exam and then notice. It could even be glaucoma. And how will you pick up glaucoma? So even though we are learning colic today, how will we be able to pick up glaucoma in a child? If the child has chronic or intermittent tearing every time there are tears coming, photophobia, corneal enlargement, corneal clouding, optic nerve capping, ocular enlargement. So if I give you these features, and I say, what are your differentials? A, glaucoma. B, episcleritis. C, conjunctivitis. D, iritis. The well-trained doctor who attended this class and took the class serious will go like, no, Dr. Boni, it is nothing but glaucoma. Doctors, please, are we tracking? We are learning colic, but we are learning all these other things which go with colic. Okay, good. What about ear, nose, and throat conditions? So I saw that I think Dr. Kano and some other doctors wrote otitis media, otitis media, otitis media. How will otitis media present in your question stem? Bulging tympanic membrane. What about thrush? Thrush will present as white plaques on the buccal mucosa, the tongue, and the palate. That is how thrush will present. What about cardiovascular? What are the cardiovascular causes of a child who is crying a lot? They may have anomalous origin of the left coronary artery. And how would that present in your question stem? A child with cardiomegaly and features of heart failure. And then heart failure itself in children can also lead to incessant crying. How will a child with heart failure present? Okay, they'll have feeding intolerance, so they can't feed for a long time. They get easily tired. That's how you be told. They are tachycardic. Their heart is racing. They have poor perfusion of the extremities. And how would that present? Cold extremities. So you have a child with cold extremities and tachycardia. It should at least lead you to think about heart failure. Tachypnea, increased work of breathing. And they can also present with supraventricular tachycardia. Okay, supraventricular tachycardia. How will they present? They'll be pale, they'll be irritable, they'll have poor feeding, they'll be cyanotic, so bluish discoloration around the lips and the extremities, and they'll be restless. What about gastrointestinal causes of a child who is crying a lot? They can have anal fissures, and you see that on physical exam. They can be constipated, where they are passing hard stools. They can have gastroenteritis, where they have vomiting and diarrhea. So a child who is crying a lot with vomiting and diarrhea, think about gastroenteritis. A child who is crying a lot, who is passing hard stools, think about constipation. A child who is crying a lot and you see a crack in the anal veg, think about anal fissures. Okay, now I have a question. If you see a child who is crying a lot with genital warts, what's your next best step?
Report to CAS.
Report to CAS. That is, report to Child Protection Services. Why? Because it could be that child has been abused. You see, this is how you prepare. This is how you prepare. This is how you prepare, right? How will I know that this point is talking about gastroesophageal reflux disease? I'm looking at a child who is irritable, who is vomiting, who has gained weight poorly, who is refusing to eat, and may have blood in the stools. That's gastroesophageal reflux disease. How will I be able to pick up GI obstruction, like pyloric stenosis, like intussusception, like volvulus? I'm looking for that child who is crying inconsolably, who is vomiting, okay? They may or may not be bilous or forceful. And they may even present with GIT bleeding. They may have forceful vomiting. And the vomiting, they will say it is projectile, so it goes far, right? And they may have a right-sided short sausage-shaped abdominal mass. So if you see that description, right-sided short sausage-shaped abdominal mass, crying infant, think about intussusception. Palpable olive mass in the abdomen, think about pyloric stenosis. So we are learning you know, the exam language. Right-sided, sausage-shaped abdominal mass, intussusception. Palpable olive mass, pyloric stenosis. Inguinal hernia. How will inguinal hernia present? It will present as a child with a bulge in the right groin or in the groin area. They may have vomiting, abdominal distension. If they have a bulge in the groin area with vomiting and abdominal distension, think about incarceration or even at worst, strangulation. That means the hernia is strangulated. So we are not just running through colic, we are just trying to learn all the various things which can also make the child cry. And that is a tall order. But if you're able to list at least 2 from each of the systems, you're good. Good. What about genitourinary? They can have meatal ulcer, usually in the male. Okay, and you see that on the exam. They can have ovarian torsion. No, that is not, ovarian torsion is not male, sorry. Ovarian torsion is female, sorry. Testicular torsion, where on physical exam, you see acute testicular swelling. Urinary tract infection, where they may have fever, suprapubic tenderness, poor feeding, poor weight gain. So if you see this quadruple presentation, fever plus suprapubic tenderness plus poor feeding plus poor weight gain, UTI. What about urinary tract obstruction, abdominal distension, plus difficulty voiding, plus poor urine stream, plus straining or grunting during voiding? Think about urinary tract obstruction. So please, even though we are learning colic, we are also learning various ways that various things can present. What about fractures? How will a child with fracture be presented in a board exam situation? You will see a child with decreased movement of the extremity, like a child who is going through the moral reflex, you know, instead of the moral reflex, you realize that maybe one arm is doing the reflex and the other arm is not able to do it. If there is localized swelling and crepitation, and if there's increased pain with movement of that particular extremity, think about a fracture. How will a child with osteomyelitis also present? Fever with decreased movement, asymmetric moro. So you realize that osteomyelitis and fracture look similar. What will distinguish between them is when the examiner throws in fever. Because all the features of osteomyelitis and fracture look similar. But then, how will I be able to tell on my question stem that this is osteomyelitis or septic arthritis? Boom. So fever with decreased movement of the extremity. So you realize that there's decreased movement of the extremity in fracture, there's decreased movement of the extremity in osteomyelitis. There's asymmetric moral reflex in fracture, there's asymmetric moral reflex in osteomyelitis. But what is one key difference that I can, you know, use to separate the two of them? Fever. Fever. As soon as fever is thrown in, you go like, okay, something unique is happening here. So that's why I say that every single word in the MCCQE1 exam is important. Every single word. What about neurologic? If the child has abusive head trauma, how would they present? They may present with seizures, respiratory difficulty, or apnea, retinal hemorrhages, you know, cutaneous bruising, associated injuries. And someone even mentioned meningitis. How will a child with meningitis present? A child with meningitis will present with fever, bulging fontanelle, they'll be lethargic, irritability, meningismus, like, you know, stiff neck, right? What about if they have neuromuscular disease like CNS disorder, metabolic disease? They may have abnormal tone and they may have muscle weakness. So what are the questions to ask on history in a child with infantile colic? Number one, you've got to ask about the feeding history. Number two, you have to ask about the stools. How are they passing their stools? Because we learned today that constipation will present with passing hard and firm stools. Meanwhile, gastroenteritis will present with vomiting and diarrhea. At the same time, intestinal obstruction may present with a child who is not passing stools with abdominal distension and vomiting. And pyloric stenosis will present with projectile vomiting, and we said an olive-sized lump in the abdomen. Well, we said that intussusception will present with, look at the wording, sausage-shaped mass. So when you see some of these words, they are buzzwords, and they must be directing you as a detective. You must also ask about urination, sleeping patterns of a child. Is a child vomiting? Because it helps in evaluating possible GI, cardiovascular, metabolic conditions. As part of your history as well, you want to go into prenatal history. You want to go into perinatal. What are the issues surrounding the birth? You want to ask about risk factors for sepsis. Was a child born prematurely? Was there any premature rupture of membranes? Was there any maternal fever? The mother have positive group B strep. You also want to find out about psychosocial history. And then parent-infant interactions. Because as the class goes on, you realize that one of the effects of colic, one of the effects of a child who is crying a lot on the parents, is that it can lead to depression. So if the child has cried so much that, the mother is so livid, then parent-infant interactions will go down. And you have to also ask about perceptions and interactions of extended family members, like grandparents and all those things. And then you also want to ask, when does the cry occur? We learned that with colic, it usually occurs in the evening. Like at what time exactly, or what activity leads to this cry? If the child is swallowing a lot of air into the GIT, you realize that they will pair the crying with feeding. Crying with feeding. So if you have a child who is crying whenever the child is feeding, think about a child who is swallowing a lot of air into the GI tract, or a child with gastroesophageal reflux disease. Those two things. How long does the cry last? We learned that colic usually lasts more than how many hours, please? More than how many hours, please? Can somebody help me? More than how many hours?
3 hours.
3 hours, good. What do you do when the baby cries? That's also another question you want to ask. It helps you to know the soothing techniques, because you will get to know that when we get to the management of colic, soothing techniques must be discussed thoroughly with the parents. What does the cry sound like to you? Most of the time, colic, will present as a disturbing form of cry. It is so disturbing that the parents feel that something very bad, something ominous is happening to the child. And how and what do you feed the baby? Because you will also realize that when we are going to the management of colic, at times there's the suggestion to change the feed. So underfeeding, overfeeding, inappropriate feeding are proposed causes of colic. And if there's a change in feeding technique, at times it can help to support, or it can help to solve the issue of colic. Okay. And how do you feel when the baby cries? That is also another question you want to ask the parents, right? And how has the colic affected your family? What is your theory of why a baby cries? So this is why I always teach our candidates. Now, still on the history, I'm going to give you some clues so that we'll use it to pick up some things. If you have a child who is crying with bloody stool, think about these 4 top diagnoses. In fact, if I was supposed to arrange these diagnoses again, I have to bring intussusception up. Intussusception should go up. Then cow's colitis, then soy-induced colitis, then anal fissure. In a child who is crying with blood in the stools, please think about these 4 diagnoses. Intussusception should be number 1. Cow milk colitis, soy-induced colitis, anal fissure. I'll say it again. In a baby, in a child who is crying a lot with blood in the stools, think about 4 differentials: intussusception, anal fissure, soy-induced colitis, and cow milk colitis. Right? Okay, good. What about if I have a kid who has bilous or projectile vomiting and crying? Bilous or projectile vomiting plus crying. What are my differentials? GI obstruction, pyloric stenosis, volvulus. Bilous or projectile vomiting plus crying, GI obstruction, pyloric stenosis, volvulus. So you realize that you thought we were just going to talk about colic, but we've added some stuff. Doctors, please, what is standing out for you today? Anyone, doctor?
Can I go through it?
Yes, Dr. Wissam, yeah, you can. You
Yeah,
don't need
for
to
me,
go through everything, but like what has stood out for you? What has been your main learning point tonight?
actually, your approach is a bit strange for me because, like, the way I do it, it's totally different. Especially when you went through crying unconsolable baby. And at the beginning of the class, the main idea it was about infantile colic. And then you just specified it, infantile colic. And then you went to head to toe approach, which is, for me, I see it totally different than what I expect. I would go directly to abdominal differential diagnosis according to the Canadian objectives. And then when you came here for the bilious and projectile vomiting, so the approach I use is bilious alone, projectile alone. The only one belong projectile vomiting is pyloric stenosis. And then the others I wouldn't omit biliary atresia and the other differential diagnosis, double bubble, three bubble.
But you realize that biliary atresia will not necessarily cause projectile vomiting.
Yeah. I told you, that's why I said projectile vomiting. The only one differential, and it's very specific, famous for it, is the pyloric stenosis. And then the biliary vomiting, that is very broad differentials. The rest of them, they go over there.
Yeah.
Like we define it above the ligament of threads and below ligament of threads, and we approach it that way. It's interesting, like I learned something different, but I just found it very broad for me. It creates some question marks in my brain. That's it. Thank you.
Sure. Yeah, and the question marks have to be there because, you know, when you're talking about bilous vomiting, that is something different. But then when you talk about bilous and or projectile vomiting, when you combine the two, then it narrows down the differentials, right? Because you realize that if you have projectile vomiting, yes, pyloric stenosis is the main thing. But then when children also have GI obstruction, they can also have somewhat, it depends on the level of the obstruction, right? And then that comes with bilous nature of the vomiting. Then it's like, okay, I have my bilous vomiting here, I have my projectile vomiting here. Where do these two meet? That is where you get, you know, these differentials. So that's very good. And I'm happy that at least like you have a way you put it together, but you're also learning a different way of putting it together. That's very good.
Yeah, thank you.